see him again, give him my regards.
We'll do that.
Yes, he is. Yeah. He was so good with my dad. Oh gosh.
Absolutely. Slide over one more.
We do?
Yep.
Oh.
Added another.
Testing. Hi, everyone. Okay, see, there it is. I'm trying to demonstrate how to use this, and meanwhile, I'm flipping. Okay, so thanks, everyone, for coming. Just wanted to let you know that Nancy-Ann should be arriving soon. And so when you use the microphone, all you have to do is press the red button, and once you see the red light come on, you'll know that it's functioning. And then when you're finished, just undo it. And so anyway, just demonstrating how it works. Thanks for coming, and proceed.
Oh, great. See ya. Good morning. Good to see you again. How are you?
Hey, Nancy. Good to see you. Thanks, everybody.
I heard that. 3 to 4 inches, right? 3 to 4 inches or more? Yeah, that's unusual. This time of year.
You know that Stephen Hoople? corner.
Great, nice to see you.
Thank you.
Thank you. Good morning, everybody. I want to thank you all for coming to, I think, what is our sixth, maybe, meeting like this that we've had at the White House. You look very scrunched in, Jeff. I don't know, it's like everybody's, I don't know, maybe we should move a little this direction. I have a little more room over here. There are a lot of people at the table, which is, I think, true when you come together to talk about a subject like healthcare. And it's great to see some familiar faces and people who I know have been working on trying to solve some of these issues of how to lower costs, how to improve quality, how to get more people covered across our country. And I appreciate your taking the time today to come together and talk to us about those subjects. So, as I said, the president kicked this off on March 6th. Is that the date it was? 5th? Okay. I have it etched in my mind because my first day was March 9th, which was a couple days after that, here at the White House. And some of you saw his remarks, and he said in his speech to Congress this year that healthcare reform cannot wait, must not wait, and will not wait another year. So we are engaged now in discussions with both houses of Congress on what healthcare reform will look like, and they are starting from the principles that the president laid out in his budget, which I will put on the table here and hope we can have some discussion around your groups or organizations and the ways in which you agree or disagree with what the president's saying and how we can move forward from here. And that's what the Congress is engaged in now. The staffs are working night and day to sort of spec out and flesh out the details of their proposals on how we're going to get this done. So I'm going to just open it up now and go around the table, I think, first and have each person introduce themselves so we all know. Many of you know each other, but we all know who we're talking to. And then I'm going to ask you some questions about ways in which we can lower costs and improve quality and get people covered. So I'll start here with you, Carlo, if you want to go around.
Sure. Thank you. Carlo DeMarco, President of the American Osteopathic Association.
Hi, I'm Glenn Tallman, Chief Executive Officer of Allscripts. We do electronic health records and e-prescribing.
Good morning. I'm Ken Thorpe. I'm Professor of Health Policy at Emory University in Atlanta, and also the Executive Director of the Partnership to Fight Chronic Disease.
Hi, good morning. Paul Diaz, CEO of Kindred Healthcare. We're the largest operator of long-term acute care hospitals and the second largest operator of nursing and rehabilitation centers in the United States.
Hi, I'm Paul Marchand. This is the Paul Corner. I represent both the ARC of the United States and United Cerebral Palsy, two major advocacy and provider organizations in the disability community.
Amy Garcia, I'm the Executive Director of the National Association of School Nurses. Our members take care of kids at school.
Jennifer Kovich-Bordenik. I'm the Chief Operating Officer at the eHealth Initiative. We're a nonprofit multi-stakeholder coalition focused on improving quality through health information technology.
I'm Susan Kelly, President of Charles Drew University of Medicine and Science in sunny South Central Los Angeles. We're one of the 4 historically black medical schools. I know, strange and wonderful things happen. Black man in the White House, white woman in Watts. But we are doing our best in the largest urban underserved area in America.
And we just had a regional summit in
I was
LA
there.
on Monday.
I was there.
think I saw you
I was
there. That's
wallpaper
right.
behind the governors.
Yes, well, that happens, that happens. Jane?
Jane Horvath with Merck.
Steve Hytov, I'm the managing attorney of the National Health Law Program, and we pay attention to the health access needs of the low-income community.
Hi, Nancy, and I'm Steve Ubel, President and CEO of AdvaMed, which is the Advanced Medical Technology Association.
Jan Naylor, President of AD Naylor and Company in Western Maryland, a 125-year-old family business. We have 4 Ace hardware stores, plumbing, heating, electrical contracting business, commercial sales division, and a Culligan franchise, and we're trying to stay alive.
And founded as a blacksmith shop, I see here.
By my
It's incredible.
great-grandfather.
Incredible.
I'm Ebony Morris with the National Urban League, with the Policy Institute here in D.C., where we do research and policy analysis.
Tom Epstein, I'm with Blue Shield of California, came from San Francisco, and we are a large not-for-profit health plan in California.
How many covered lives?
We have about 3.5 million.
Hi, I'm Paul Bassaro, currently sitting in the wrong spot.
Yeah.
CEO of Watson Pharmaceuticals, generic company, but I'm also vice chairman of the Generic Pharmaceutical Association.
Great.
I'm Adolf Falcon. I'm the senior vice president for the National Alliance for Hispanic Health, organization that delivers community-based services to about 15 million Hispanics every year.
Hi, I'm Jeff Levy. I'm Executive Director of Trust for America's Health, which advocates for a stronger public health system and making prevention the centerpiece of health reform.
Thanks. I'm Trevor Fetter, CEO of Tenet Healthcare. We operate hospitals, and I'm also this year's chairman of the Federation of American Hospitals.
I'm Richard Bracken, president of HCA. We operate 166 hospitals in 20 states across America.
And my friend Vic Campbell is here with you as well. Hey, Vic.
I'm Tony Welters, Executive Vice President of United Health Group. We serve approximately 70 million Americans. I also, Susan, chair the board of the Morehouse School of Medicine.
Wow. That makes 2.
Good morning. I'm Dave Snow. I'm chairman and CEO of Medco Health Solutions. We manage the drug benefits for about 65 million Americans. The other hat I'm wearing today is I'm the chairman of the Pharmaceutical Care Management Association, which represents all the PBMs in the country.
Good morning. I'm Ann Stausball, CEO of CalPERS, the California Public Employees Retirement System. We purchase health benefits for the state of California and about 1,100 local agencies in California. We have about 1.3 million members.
I'm Kathy Butow, Vice President for Health Policy at Johnson & Johnson. We have pharmaceutical, medical device, consumer products, and health and wellness programs.
I'm Paul Vandewater, a senior fellow at the Center on Budget and Policy Priorities, which is an organization here in Washington that advocates for programs that help low and moderate income families.
I'm John Meyer. I'm a heart surgeon at the Children's Hospital in Boston, on the faculty at Harvard Medical School, past president of the Society of Thoracic Surgeons, which is the organization that represents about 5,000 both national and international heart and lung surgeons in the United States, and a veteran of 10 years on the Relative Value Update Committee of the AMA. So I have that perspective to bring as well.
Randy Ruda, Executive Vice President for Public Affairs for Easter Seals. We're the largest provider of disability services in the country. Served about 1.3 million people last year and their families, focusing on people with disabilities, chronic conditions of all ages.
I'm Pat Ford Regner. I'm the CEO of the American Academy of Nursing. Think of us as an ION, the Institute of Nursing in a way, and we're a policy think tank for nursing across the board, and we're promoting practical solutions and innovations that are both nurse-led and interdisciplinary to care for both public and private patients.
Good morning. I'm Deanne Friedholm with Consumers Union. We're the publisher of Consumer Reports magazine, and also we do Best Buy Drugs, which is a comparison of different types of drugs for different kinds of services available to the public.
My name is Mike Bray. I'm the president and founder of Bray Corp. We're best known in this area for a small chain, operating a small chain of retail toy and hobby stores called Hobbyworks. We have about 50 employees.
Good morning, I'm Brooke Lehman, and I'm with Family Voices. We're an organization that represents the needs of children with special health care needs, and our focus is on family-centered care.
Good morning, I'm Scott Armstrong, President and CEO of Group Health Cooperative. We serve 600,000 insured lives across Washington and Idaho, but we're distinct in that we also run the largest integrated care delivery system in the state of Washington with 35 medical centers, 900 plus providers that are employed by our healthcare organization.
I'm Al Mixon. I'm Chairman and CEO of Invacare Corporation. We are the world's largest maker of medical products used in the home, and I'm here to represent the home care industry. Thank you for having me.
And Don Schumacher, President and CEO of the National Hospice and Palliative Care Organization here in Alexandria. About 1.4 million people received hospice care last year, and of that, about 90% of our members took care of all of those individuals.
Wow, this is a great group and a lot of different interests represented, but I think I want to start off just by focusing a little bit on the small business representatives who are here. Mike, you said you have 50 employees, is that right?
Depending on the time of year, between 45
Yeah.
and 50.
And Jana, how many did you say you have? Okay, so I guess I'll start off by asking the two of you, and I'll let you start, Mike, what you're facing now with providing health care coverage, and what solutions do you need
Sure.
answers to?
Well, you know, we've gone in the last 12 years from paying 100% of our employees' healthcare costs to, in the last 2 years, shifting not only a burden of the premium payments to them, but switching to an HSA this past year. In the last 2 years, we crossed an age band as well. So in the past 2 years, even in Maryland, which has sort of a mandated small group for insurers, our costs have increased 28%, 15% from 06 to 07, and then another 13% from 07 to 08. And all the while,
even with an HSA?
We're switching to an HSA. So the switching to an HSA this past year has simply sort of stemmed the tide. What's going to come next year, I don't know. But I could certainly say, being in retail, we pay pretty well for retail. But still, you know, the plan we're on now, if it's a family, their HSA deductible is $2,400. And I personally think that's an awful lot to ask of somebody who may be only making $45,000 a year and whose spouse or partner may be only making the same thing. So if you've got those two people living in the DC area, taking care of their families, this is, I just have to tell you, it's a huge burden. And I hear stories coming back from my employees all the time now about how they're making sort of these cost-benefit decisions, and sometimes I think in the wrong direction. You know, shifting, putting off what I think would be important care because they just can't afford it now. And I can't help them, because if I give somebody $1,000 to get through a tough spot, well then I pretty much have to give to everybody, and that's just not something I can afford to do.
And have you had specific instances where you've had employees who are very ill? I mean, what do you think is causing the cost increases that you're seeing?
Well, I mean, we do. There's an example that you know, I have an employee who has a chronic condition and now has contracted a condition that can be cured with antibiotics. But because of the medication he takes for the chronic condition, the antibiotics he needs to take are very expensive. I think the cost is $5,000. So he's going to chew up his entire deductible all at once. So, you know, you're asking this guy to pay $2,400. So instead of solving the problem in the short term, what's going to happen is he's going to continue sort of doing the maintenance care. And I frankly can't see how that's a better solution to the problem, to have him just keep paying and keep paying and keep paying and keep paying. We could just make this problem go away. Something he literally would not have had to deal with 1 year ago. But in making this attempt to save costs for my company and for my employees, suddenly he finds himself in this spot.
When do you have to sign up again for next year?
September. So we've sort of got to hold this off until September. But I can't say that I'm going to offer a different plan.
Jana, from your perspective, what are you seeing? You're in Maryland as well, right? So,
Far western Maryland, up in the mountains, rural Appalachia. My income levels vary from 18,000 to 69,000 in my company. And $18,000, if you were to cover yourself, I can afford to pay now 70% of the premium for my employees. I pay 50% for dependents. With a standard plan, that's $1,733 per year that individual has to pay out. That's 10% of their salary if they make $18,000. That's too much. Likewise, if they wanted to cover the whole family, a spouse and one or more children, their cost is $7,567 a year on a standard plan. The total cost is $17,500 to our company. This year, I went back to my insurance agent and I said, we've got to do something else. I've got people that are 40s and 50s that are dropping health care because they can't afford their part. And I said, some of these people have had major surgeries in the last 2 years. One had nerve damage that was destroying the use of her right arm, and she's right-handed, and she needed surgery. And it took a year to get the permissions to have it. When she had coverage, it cost $103,000, and she's back to work now. She dropped coverage last summer because she couldn't afford her 30%. I knew she's at an age, she's 51, she's going to be needing more health care. Well, you can't operate at that age without insurance and not go bankrupt. So I said, come up with a better plan. So we have now what we call the lower cost option. The company pays the same amount as we would for the standard, but it brings it down to the individual to $14.28 biweekly, or $371 a year for coverage. That woman who had dropped it picked it back up. I said, I don't want you people going bankrupt. You're my friends, you're my colleagues. You know, we've been in business 125 years. I've been there 29. You can't drop health care. I said, I can't afford it. Any rate, for the family on the low cost option, you don't get any benefits until $2,000. You've spent $2,000 out of your pocket. And then you get the co-pays until you hit $3,000. And after that, pretty much everything's covered. You do get one visit to the doctor for a physical for free, and a couple of basic tests, as long as it's not the same test that's run every year. Like if you've got high cholesterol, that doesn't count. They won't cover that. But to cover the family, the out-of-pocket on this high deductible thing is $3,400. If you're only making $18,000, that's huge. In the 60s, we offered 100% health care for everybody. It was 0.16 of our net sales. We have 90 to 95 employees, depending on the season. I think we have 48 people covered this year. We had 45 covered last year. We got back 3 with the lower cost option that we provided. If I don't offer health care, I can't keep my veteran employees. And my veteran employees cost more because they're older.
So it sounds like only half of your employees take it now.
Right, but there's about another 30 that are covered through a spouse somewhere.
Right,
But
okay.
I do have about 20-some people that aren't covered anywhere, and some of them need to be. And some of them will be going bankrupt the next time they get sick.
Well, got a lot of smart people around this table. Let's talk a little bit about what we can do to control cost. Dave Snow, talk about what you think we should be doing to control costs.
Obviously, it is a cost problem, and there are lots of opportunities. And what I've been talking about a lot is that we need to understand that to get to real healthcare reform, it's a building block approach, starting with wiring healthcare. But once we wire healthcare, it's my strong view that we can tackle the problem of chronic and complex disease, where in fact it's estimated $350 billion a year is wasted due to non-compliance at the patient level. And there's also an issue around the evidence-based protocols that are promulgated around the treatment of disease. We see enormous disparities in how disease is treated across the country. It could be geographically, it could be by age, or it could be by training. But $350 billion a year goes a long way to funding the uninsured, helping those employers, those smaller
employers who are clearly having problems right now. After that, I think we should go after tort reform. It's $200 billion a year. I believe if people are practicing to protocol, physicians are practicing to protocol, we should hold them harmless from malpractice. It's malpractice insurance plus defensive medicine. It's worth $200 billion a year. Finally, and this is the hardest thing to do, I'd focus on that last year of life issue in Medicare. It's another $130 billion a year. It's 1/3 of the Medicare budget every year. You add it up, it's $700 billion a year. To me, the Obama administration is doing the right thing by talking about wiring healthcare first, talking about what we can do for chronic and complex disease second. And I wouldn't tackle the other things just now.
I was going to say, and tell me how we solve
there.
it. And by the way, I think everybody knows, but C-SPAN is either taping or televising this. So to the extent you can, when you say wiring healthcare, everybody around here knows what we're talking about. But let's spell it out a little bit
I
so
need
that
to explain
everyone
that.
can explain.
I need to explain that, and I'll tell you why. My father is a physician, and when he hears electronic medical record, he sends me an email saying, "Dave, how can you say that's a good idea? It won't save the country a dime." And I go, "Dad, what do you think wiring healthcare means?" And he thinks it means taking a paper record in his office and putting it into his computer. And I said, if that's what you believe it means, then you're right, it won't save us a dime. And I think a lot of America does not understand the power of wiring healthcare, because what we're really talking about is a patient-centric record, so that no matter where you go in the system, a provider who's laying hands-on care to a patient can see what's going on, can see whether the patient's compliant with their meds, can see whether in fact that patient's doing what is protocol. See if, in fact, that patient is unstable because perhaps they had some emergency room visits. All those things that are now in these discrete silos across our system really need to be accessible by anybody who's taking care of a patient. And the evidence is clear. Caregivers are trusted by a patient. And if they have full information, they have the ability to engage and influence in a way that a third party can't do. It's a caregiver who can do it, whether it's the physician, a nurse, a pharmacist. But if they can't see it, they can't help. And so wiring healthcare is key to everything. It's transparency, especially at an ambulatory care setting. Because the truth is, if we get it right in an ambulatory care setting, we avoid the emergency room visits and the inpatient hospitalizations. And we are in a black box right now. No one can see anything.
I see Dr. Meyer nodding, so I want to give him a chance to get in here.
I'll make a few comments. This instrument, or maybe it's a keyboard now, still controls 75% of the healthcare expenditures in the United States. And I think there are a growing body of physicians, certainly in our specialty and some of our other medical specialties, who I think get it, that we have a responsibility to society as a profession. We get certain privileges and prerogatives, but we have responsibilities too. And I think there are an increasing number of us who understand that. And I think that we are pretty convinced, both on our own database experience, the STS database has now got 85% penetrance in cardiac surgical centers around the United States, 3.6 million patients or whatever it is in the database. And I think what we've been able to show, I think what our colleagues in cardiology have been able to show with their interventional cath database is that collecting data on every patient, feeding it centrally, having it risk adjusted, and then fed back to the individual practice or institution or physician level changes practice. We can use that tool to make how we take care of patients better. And I think, there is enormous power in that. I think there is a real need at the policy level to sort of get that profession part back into the discussion. I think that there are a variety of ways that one might think about doing that, both with changes in the reimbursement system as well as other things. But I think those two key pieces are engaging us as a profession rather than trying to regulate or throw economic carrots and sticks or something like that, I think is one. And the other thing is, we've funded our database entirely ourselves, but I think there are a lot of other specialties who are now interested, particularly surgical specialties, and they need help. I mean, this would be the biggest return on investment that I could imagine and I think there are a lot of signals that there's interest at the federal level in supporting these things, but I think that's really going to be a big return on investment.
As you know, the President and the Congress enacted in the Recovery Act
Right.
$19 billion for wiring healthcare, for providing the money for physicians and hospitals to do electronic medical records. What's your reaction to that, and what should we be doing to move faster?
I think Dave's right that, we do have a lot of stuff in silos.
Mm-hmm.
And I mean, even though we have this huge database, we only get out to 30 days. We can't link to the Medicare, data clinic, their cost database. And we're trying to do that right now. And, we need those hurdles sort of abolished so that, and I recognize there are privacy concerns and things like that, but there are ways with dealing with that electronically. And we've already got those arrangements made at our data warehouse that's managed at the Duke Clinical Research Institute. And I think we can really, because it's the feedback of data to the individual physician. It's the feedback of, why am I costing more than my colleagues and peers around the country? Why are my outcomes not as good as my peers across the country?
And you're open to that, because that's been an issue in the past where some, at least I've been told, some clinicians are not open to hearing that, or perhaps they are worried about how that data would be used.
Well, I think probably the biggest fear is the other one that you touched on, which is it's going to be a gold mine for trial lawyers. Not to single them out, because I'm sure we all bear some responsibility in where we are right now in the healthcare system. But I think that's the major thing. I can tell you when I floated this idea at a convocation of surgical groups that the neurosurgeons were running for the hills until we actually sort of got into it and explained how this could actually work and stuff. And now they're actively out there trying to form their own database. I think there's actually a pretty big appetite for this, because what we all want is we want to do what's best for the patients, and that's the individual patient as well as patient population writ large. And I think if we have the tools, then I think we can push this ball down the road and really improve what we do. And I think we can't walk away from the notion about how much is being spent on healthcare. This is part of our responsibility. And as I say, this instrument, or maybe it's a keyboard now, still controls a lot of what goes on, and we need to do better.
That's great. I want to just recognize my colleague, Dr. Bob Kocher, who's here, who's an oncologist who works at the White House and the National Economic Council. And I was scanning the room. I think you're it, Bob. So we need to follow up with Dr. Meyer after this on some of his ideas, because they're great. Pat, you want to speak to nursing in this?
Well, certainly we support the stimulus effort to wire up everyone. And, the only caution I think I just throw it out, is something that we're spending a lot of time on. We did drill downs in 25 hospitals with nursing staff and other key staff on acute care units. And, our message after the results, we took 2,200 different examples from them, but around the IT piece, I think it's just critical that whether we're talking about hospitals or integrated systems or big community systems, that all that there be teams that decide on what is purchased, what is deployed, what is designed, what is used, because if it isn't going to work. And we were hearing from both pharmacists and nurses in many settings that the hospital bought X or Y, and it's not talking to B and C, and they're still doing, instead of caring for patients at point of care, they're still putting in handwritten notes, and then the other part of it's going into computerized notes. And then we're also not capturing nursing's work in those systems. And so we've been, we're working with the industry, we're working with the designers, but I think it's just something to be sensitive to. And we had to fight to get nurse practitioners in the legislation who have primary care practices, and we have to stop doing that. We have to. We need to work to interdisciplinary, and we have a lot of work to do about training people at the front end on that. My colleagues and nurse educators are trying to bring all of the different student levels up, in terms of IT and other things. But it's going to take some time, and it's going to take some real effort and a joint effort and a cross effort between professions to make this work.
Well, and it sounds like you said this, Dr. Meyer, we have to start with the patient. The patient's first, and the problems that Pat talked about, and you kind of have to be solved if you're looking at it from the patient perspective of what makes the record best for them, as opposed to, gee, this is a nifty thing in my department of the hospital. So I want to switch gears just a little bit and get Steve Ubel into this discussion. Your members produce some incredible life-saving devices, and yet we've been hearing all the discussion about costs, and we know they're expensive. So what do you think? What do your members think about what we should be doing here?
Well, first, thanks again for the opportunity to be here. I'd make a few points. The first is our board has been working through healthcare reform with many of the stakeholders around this table, and I can just tell you that we're all in, and we're very supportive of the administration's efforts to get everyone covered, to control costs, and to reorient the system so that the incentives change to again, better control costs and improve quality. But we're very concerned that we want to make sure that we preserve innovation in whatever reforms we pursue, because we know that technology and innovation have really delivered both for patients and for the economy as a whole. If you look at the last 20 years, lifespan is up, mortality is down through a range of conditions. Heart attack mortality down 50%, stroke down 30%, breast cancer 20%. And in the overall economic picture, our members are delivering high-paying jobs and exports and bringing patients back to work. Ken will tell you that chronic disease is a crushing cost to the system and to the economy as well. There was a recent Milken study that found $1 trillion reduction in GDP attributable to chronic disease. So we believe that as we reform the system and change incentives, that we must preserve those incentives to continue innovation going forward.
Great. Ken, you've got me trained now. When I hear chronic disease, I think of you, so.
Well, that's good.
Yeah. So
I'm glad to hear that.
Why don't you chip in here?
Well, sure. I wanted to go back to this two small business owners, because I think if there's ever a case that was just made for health reform, you just heard it.
Mm-hmm.
We're in a vicious cycle of trying in the short run to save costs by increasing copays and deductibles on exactly the wrong types of folks that we shouldn't be increasing copays and deductibles on. So we're not going to solve this problem of healthcare costs through a benefit redesign and hiking up copays and deductibles. That's not really the solution, but I understand in the short run, you have few tools to really do this. So I think the opportunity here for health reform is to do two things. One is to make sure that we're solving the right issue. And on that front, as Steve was mentioned, we like to point out that there's really three key things that we need to focus on dealing with. One is that we've had an explosion in this country of chronic illness, much of it linked to a doubling of obesity since 1985. So the facts are that 34% of adults today are clinically obese. It was 17% in 1985. That doubling by itself accounts for about 30% of the growth in healthcare spending. So it's an enormous amount of disease-driven push in the cost of health insurance premiums in the Medicare population and Medicaid. So that's point one. Point two is that we do now spend about 3/4 of our dollars are linked to chronically ill patients. And if you think about how we pay for and provide healthcare services, Pat was just talking about this, we don't have a model in terms of how we deliver services, how we incent patients, how we work with patients at home to really manage chronic diseases in an effective way clinically or in an effective way cost-wise. So we need to really reform the whole delivery model. And we need to reform how we pay for that service as well. And the third thing that I would point out is innovation is something we need to make sure that we take care of, but we do need more information. We need more information on what works and what doesn't work. There's thousands of ways to probably treat a different patient in terms of different meds, devices, and so on. Those clinicians and families need the information on the comparative effectiveness of different treatments. So I would hope that as the administration is looking at this, and I know from then candidate Obama's health care plan, that he is really focusing on the issues around primary prevention, How do we prevent disease in the first place? How do we redesign the delivery model to more effectively manage chronic disease? And obviously, putting into place a structure that can really do comparative effectiveness research. And just, I guess, in closing, this problem really goes beyond the healthcare delivery system. If we're going to really deal with this effectively, we really have to look at innovations in how we deal with kids at schools, how we work with people, and Jeff can talk about this in the community, with community-based prevention, and how we can work with workers at the work site and really look at some innovation in health and productivity management programs, in addition to developing some of the capacity that you've heard about to manage patients that have chronic disease. So I think the case for healthcare reform is pretty obvious. We're not going to solve it through co-pays and benefit increases. We really do need to look at this as a system in terms of reform, both on the prevention side, the delivery system side, the payment side, and getting the incentives right.
That's right. Jeff.
I could just build on what Ken talked about. I think one of the things the President said when he signed the Recovery Act was acknowledging the $650 million in the Recovery Act that's for community prevention. And the comment he made, which I think is incredibly important for this discussion, is that we need to prevent illness before people even enter the clinic. And disease management is incredibly important for people who already have these chronic conditions, but these are very preventable conditions. We have evidence-based, proven interventions in the community that can address physical activity and nutrition and smoking cessation, which are the biggest drivers of the chronic disease costs. And at a fraction of the price, the work that can be done in the community will either prevent or mitigate those conditions. And so we really need to be thinking in the context of health reform about that kind of return on investment. It's not going to save $1 trillion, but it will save many billions of dollars. But we need to make sure that those people in the community doing that work have the resources, and that's everything from community-based organizations to public health departments. And we need to make sure that what happens in the community is well integrated with what happens in the clinic. A lot of the medical community is now talking about exercise as medicine, but doctor can write the best prescription for exercise, and if there's no opportunity to exercise in the community, it's not going to be an effective intervention. I just want to come back to two other points. One was the end-of-life costs, which is there's more and more data now about obesity in particular being additive to Medicare costs rather than necessarily shortening lives, or not shortening lives enough to be, in quotes, a savings, which is not quite the way we want to look at things anyway. But if we addressed those chronic conditions early enough, then we actually could see some serious Medicare savings. And the second comment I wanted to add was about wiring and who we are wiring. And part of that wiring has to be public health agencies. And as we're designing the system, making sure that the information public health agencies need for traditional disease surveillance, and therefore not having all these stovepipe systems, but also because public health agencies can play an incredibly important quality assurance role. In New York City now, they have actually been doing outreach and doing work, providing electronic health record systems for small providers. The people who are going to find it hardest to invest in these things. And they're doing it, A, by providing the financial support, but also because they're providing this kind of quality assurance feedback and can really target, very important public health and high-cost conditions. And so there's a continuing role for public health agencies, not just in the traditional things you think about disease control and community prevention, but also even in the quality assurance side in a reformed system.
So there's so much more we could be doing there. I want to recognize Susan. I'm going to go to Paul Diaz to talk about what he's seeing with some of the sickest patients out there. Susan?
Well, thank you, and thank you for the opportunity to be here. It's, there are just two things I really wanted to highlight. One is that well, as I said, we're in the largest urban underserved area in America. It's 1.6 million people with one hospital, where our health outcomes are actually worse than most third world countries. We are lodged somewhere halfway between Bangladesh and South Africa for the number of doctors per 100,000 of population. The average black man dies at 55. And we're the national epicenter of double amputation from diabetes, and the major killer of young black women aged 25 to 34 is HIV and AIDS. And the infant mortality and low birth weights are actually outdone by Turkmenistan. These are extraordinary figures. We have, as I said, one ER in the area, that's at St Francis, but the issue is that we have 70% of uninsured people. It was a 95% African American area, it's now 70% Latino. The healthcare is worse than it was at the Watts riots, which formed this institution and formed this hospital, which is now dead, the Martin Luther King Hospital, and may live again, but hopefully in my lifetime. But one of the issues that I think is, I mean, I couldn't be prouder to have been sworn in as a citizen on September the 11th and got my thing to vote and got to do my vote. My first vote in America was for this man. And so I couldn't be happier and prouder of that. But I have to say, leading a historically black medical school for these last 3 years and seeing that, you know, half, as I understand, half of the increased longevity of white men is attributable to that 81 milligrams a day of aspirin. Well, black men don't get that. They don't get primary care. They go to the ER when it's too late. And, you know, we've got 10 times the death rate from cancers for Latinas in the area because they don't get primary care. We've just started our first urgent care clinic. But my bigger point is really what seems to be missing from the health reform debate at the moment is the health workforce shortages issue. And I come from Australia. We have a combination of a big safety net and private health care as well. So everyone's covered. Whether you're born yet and you're just nearly dead, you're covered from the cradle to the pre-cradle to the grave. And it's a treat. It's wonderful. Nobody goes bankrupt. I heard at the forum on Monday that every minute in America somebody goes bankrupt as a result of a healthcare crisis. That's when they haven't been moved out of their homes because they're subprime as well. You know, it's really a disaster. The issue, though, for us is that you could get health coverage up. You could get everybody covered. You can get the cost down to Australia. I mean, America's 19 out of 19 on the deaths from preventable diseases in hospital-based, you know, accidents and stuff. It's really terrible. And in South LA, our average income is $11,000. I'd pay more than that in healthcare. $11,000 is the average income. And within a 5-mile radius, the average person spends, pick a number, in 1 year, they spend in the area, how much on healthcare? 98 cents. Because there isn't any healthcare. They are poor, they are not covered, there is no healthcare. And so there's nowhere to go. So they don't go, so they die. Unless they're Medicare covered, then they trek up to Cedars-Sinai, along with, you know, Dennis Quaid. They go to Cedars-Sinai with their Medicare card because they've got diabetes or they're over 65 and they're covered. But that's 2 trains and a bus to get there and a full day and a day off work, which means you're not looking after your kids or your elderly parents. It's really a disaster. But you can get the healthcare costs down and you can get the coverage up, but you will not solve the problem if you don't have enough healthcare providers. And it's not a doctor solution. I really do believe, and I speak also here for my good friend, Dr. Jack Stobo, who's Senior Vice President for Health Sciences and Services at the University of California System. I was with him. He was the wallpaper next to me behind Schwarzenegger on Monday. And doctors are probably 20% of the solution. It's nurses and nurse practitioners and rad techs and health information technologists and a whole range of people training as a team, working as a team, sharing information, but basically having a patient-centred approach. But it cannot be done by doctors. You could start now and you would not have enough doctors in California in 50 years' time. Because, I mean, Australia's starting 5 new medical schools and it's 2/3 the size of California. And California's thinking of adding 80 places. 80 places? It's not a doctor solution. But once you do doctors, you've got to do residents. So CMS needs to be totally reconstructed on how you fund residency training. California already has a shortage of 17,000 specialists. We used to train 40% of the minority specialists in this country until Martin Luther King Hospital blew up or broke down or was allowed to fail. So, I mean, these are really enormous figures. It's a 3-part solution. It's about cost, it's about coverage, and it's also about a range of health professionals who respect each other and work together. I am the first educator to lead Charles Drew University. All my predecessors were African-American male physicians. So they really went not out of the box, but off the planet for a solution. And we have started the first new nursing school in California for 40 years. The only one based on health inequities. We've got 250 applicants. We haven't advertised anywhere for the first cohort, and we've got more than enough faculty. And they said, you'll never get faculty. There's none out there. Well, they have stepped up and said, I am going to change jobs and come out of retirement. This is a job worth doing. So I just think it's got to be, you have to have education in there as a major player. And
That's
that
a real
means
important point.
there needs to be funding for a workforce to address the workforce shortages. So thank you for listening to me.
Thanks. Paul, talk about your industry and what you're seeing out there.
Thanks, Nancy-Ann. Again, I want to commend you and the administration for advancing these discussions. I mean, I think what's evident in this room is the amount of passion and energy and momentum that there is behind this, and the significant amount of common ground that is shared in terms of, the issues. Clearly, coverage and cost are linked. That there's no question that we can't separate the two. I think to Ken and Dave's point, we see every day, in terms of your question, the effects of not intervening early. And quite frankly, one of the things that I struggle with the most with my nurses is going to the break room and seeing people smoking and seeing people, who are caring for people on ventilators and complex wounds with lots of comorbidities. And so we've seen as an employer the opportunity, within our infrastructure to talk about wellness, to create, financial incentives for people to participate. And we're excited about that because that also reinforces people's commitment to our patients. In terms of the broader healthcare reform opportunity, though, I think it's important to link coverage, delivery of care. Information technology is certainly part of that, but I think doctors and nurses are still the key here, particularly in the short term, and the leverage there, and the payment. And there's just so much dislocation between Medicaid and Medicare and the private plans, and not popular, but as compared to the financial services industry, our transaction costs are significantly higher. So in the short term, without rationing care, there's great opportunities to do what Medicare and Medicaid don't do, which is case manage and coordinate care. And there's a lot of great work that's been done around the country in that regard. And so what we see is often the transitions of care are not well managed. Patients do not have an advocate, and I think it's a physician-directed nurse case manager that can help navigate these places and save a lot of money, both and a lot of human cost in terms of the care coordination. And I think a lot of what we're hearing here today is that we need to get out of our silos, and that the public-private ideological divide is really not constructive. I'm excited about the opportunity that this conversation seems to be moving us past that.
That's great. Richard, talk from the hospital industry perspective. I know you've been in the industry for at least a couple of decades, and well, I know that because I've been around a while too. So we've both been there together. So talk about what you're seeing in terms of bad debt, in terms of people coming without insurance and the cost.
Thank you, and I do applaud you and the administration for taking this issue on. We couldn't be more behind the notion of healthcare reform. It is necessary, and it is necessary now. When I made my introductions, I mentioned that we have a big hospital system, 166 hospitals in many markets in America. And what that general number doesn't say that in some of our markets, we represent 25, 30, 40, in some cases 50% of healthcare services provided in some of America's largest cities. We provide about 5.5 million emergency visits each year, and 1 in 5 people that show up in our emergency departments do not have funds, do not have the ability to pay. So for us,
has that increased? Because I've been hearing there's problems in
it's
some
up.
of the emergency
It's sort of
rooms.
slowed down real recently, but it's certainly escalated dramatically over the last years. And to us, increased coverage isn't just a goal of reform, it's got to be the centerpiece. We have got to think about the reform agenda first, about what we can do to provide health care coverage for all Americans. To hit the system for the individual to be able to hit the health care system at the right time, at the right place, and in the right setting isn't just good humanity, and it isn't just good medicine, it's good economics. And so that's got to be the centerpiece for the reform agenda. On the cost side of the equation, I look at this as from a very practical standpoint. 60–70% of our cost in our hospitals is either labor or supplies. And for us to make meaningful differences in our cost structure, which is already very tight, we have to take on variation that exists in our both administrative and clinical processes. For us, we think we've done a pretty good job getting after the administrative side of the equation. But the real opportunity, as the physician mentioned earlier, is how do we take variation out of the clinical processes over time? And to get that done, and to get that done efficiently, we have to have the collaboration of the physicians into the solutions. To design a top-down solution that works good at a theoretical level, but does not take into consideration how healthcare is organized and structured in America is doomed to failure. And so how doctors and hospitals work together, how incentives are created to allow doctors and hospitals to work together, I think is a fundamental part of the equation and should be part of the review. We believe that minimizing variation in these processes holds much promise for improving cost affordability. But it's going to be an uneven path to get there. If there were easy solutions out there, they'd be in place right now. And so I would just end by saying that as we think about reform ideas and agendas, that we just don't assume that they're all right, that we test them. In our company, when we have a good idea, we get the involved people around a table, we talk about it, we design it, we test it in the market, we take it back, we refine it before we go for a company-wide deployment. And I think some of the things that we're thinking about in reform would do well to follow that kind of a logic. They seem good now, but it's the test of the marketplace, it's the test of the existing infrastructure, I think, that will really drive sustainable affordability improvements.
Tony, did you have something you wanted to add?
A couple of things, observations. One, as a company, we're firmly committed to reform. And it's not something that's new. Indeed, back in '01, we wrote every member of Congress and said it was time to do something. As we think about it, though, it's the hard decision-making we have to come to grips with. We have to bend the trend in healthcare cost escalation. It is unacceptable to have a society where healthcare costs outpaces GDP. It is something that's not making us competitive, and it's something that over the long haul will put us really in a hole. So I applaud the administration. Now is the time. Now, having said that, the hard side. As we think about our infrastructure, as we're structured today, we cannot ensure access to quality care if 5 or 10 million people showed up. So we have to fix that. What do we do about it? Let's talk about taking our hospitals, our facilities, and let's start operating 24 hours a day, 7 days a week. Let's talk about doing transplants on the weekends. Let's be engaged with surgeons and say to surgeons, if you're prepared to do that, we'll give you added incentives. We can create some more jobs. We can get greater efficiency and productivity out of our facilities. This issue around the end of life. My mother died at 93. She had an advance directive. My father died at 77 with Alzheimer's. He had an advance directive. We're not incentivizing, we're not educating the elderly about that. We need to come to grips with that. We're thinking about hospice in a narrow setting. We have to broaden the setting for hospice. When we talk about technology, it's not just healthcare technology, it's technology across America. And so we need to see our industry leaders in technology at the table, achieving issues around interoperability. We need to do that. It makes no sense that in 1980, we were producing 7.3 physicians per 100,000. Now we're down to 5. Primary care docs are not the solution. We need nurses, we need nurse practitioners, but there's no way we can say at the current rate we're bringing value added. And then to those underserved communities, we have to be very realistic. We're going to have to make investments in those communities. Real dollars, real talent, real people, feet on the ground. If we're not prepared to do that, this is a great discussion. It'll make us all feel good. And as we said in '01, we'll be writing a letter a decade from now. Because we have to make hard decisions. They're not pretty decisions, and they will challenge us all in our core businesses. And if we're not prepared to make those sacrifices, let's be clear about it on the front end so we don't waste a lot of time and energy.
Thank you. We're talking about end of life, so I wanted to turn to Don.
Thanks, Nancy.
a minute here.
I'm glad to hear you say those words, and United Healthcare has been one of the bigger supporters of the hospice industry in this country. I'm also glad to hear that you had a good hospice experience. Appreciate the administration's attempt to try and wrestle this big gorilla to the ground, the big McGilly being the last year of life, which is, of course, a very complicated time in a patient's life and a family's life, and the demand for attention and education and training grows by leaps and bounds every day. Right now, there's 1.4 million people receiving hospice care in the United States. About 930,000 of them will die this year, out of the 2.4 million people that will die this year that would be appropriate to receive hospice services. I still get phone calls and letters and emails from patients and families who say, we wished we'd come into hospice sooner. We didn't hear about it until the last 2 days of my mother's life. The physician didn't tell us that she was terminally ill. We continued along an aggressive therapeutic mode, receiving third, fourth, fifth line chemotherapy, none of which was helpful to my mother, and nobody told me that she was actually going to die from this. It's not a case of, from my perspective, of pointing fingers. It's a fact of trying to educate people, not just in terms of the expensive cost of the end-of-life care, but the human cost and the fact that people don't have a chance to say goodbye, don't participate in the process of dying. All of these things accumulate. I think I'm a clinical psychologist by training, leaving a long shadow in patients' and families' lives, that the fact that the mother or the father, someone died without the opportunity to say goodbye. 2 years ago, a study came out of Brown University that showed that on average, hospice saves $2,300 per patient when compared to like patients who are not admitted to the hospice program in their community. And we could save the federal government $2 to $3 billion a year in terms of reducing futile treatment, futile costs for patients who are not going to be recovering from the treatments that they're receiving that are being geared towards cure as opposed to care. The hospice Medicare benefit, been around for 25 years, and Nancy-Ann knows. Some discussions on MedPAC's part at wanting to tweak the benefit. We support tweaking the benefit, but we'd like to expand the benefit that would have an education case management component so that there would be a chance for us to have these conversations. I think somebody down there mentioned care management, case management earlier. We would like to help people make better decisions before they actually get to the point of imminently dying so that they can recognize, this is an alternative that we could have that would give us the peace, the comfort, the dignity, and to the federal government a much better way of saving dollars than perhaps continuing along in a very aggressive treatment mode. So we appreciate what it is you're trying to do to wrestle this to the ground, and like to find ways to increase access, to make sure that people have advance directives so that you know what it is that you're receiving from your physician and from your healthcare system, and you have the right to choose a better way of dying.
Thanks. Carlo, you had a point you wanted to make.
I appreciate the opportunity to speak today, but as president of the American Osteopathic Association, our profession has started more medical schools in the last 10 to 15 years than anyone else. We have 2 schools in California, Pacific and yes, Western and Touro in San Francisco. In general, our graduates, 62 to 63% of them go into family practice, but that's been decreasing, where the allopathic side's about 31%. That's out of JAMA from September, in the September issue. Part of the workforce issue is the debt load that these students come out with. Our medical students have an average of $250,000 debt load when they're done. And the reason they don't go into family practice, they rather go into a specialty where the reimbursement is different and they can pay their debts quicker. And as far as the workforce issue goes with just physicians in general, we have 3 new schools in the pipeline at this time. And we're great advocates of the patient-centered medical home because we believe in the entire team. I echo everyone's issues here, but you have to work with nurses, physical therapists, et cetera. And as a surgeon, I'm an ophthalmologist, my residents are well-versed in IT and informational and sciences. And they do comparative studies for our implants. I'm sure Dr. Mayer would agree. There's a lot of heart valves that if you start looking at the comparative studies, some of them cost us too much and they do the same job and they're not worth it. And we have the same issues with implants with lenses. So I just wanted to bring that out there, that the informational component is extremely important, where you get patients who go to 6 ERs and get 6 opinions with 6 CAT scans and no one catches it till the 7th visit. And that happens all the time. Thank you.
That's definitely a cost issue. We've got two really smart people here from the pharmaceutical industry. So I want to call on my friend Kathy Budo and Jane Horvath and get their thoughts on some issues they've been working on for many years.
Okay. Thank you, Nancy-Ann, and again, thank you so much for inviting us to this meeting. I have been thinking and listening and wanted to mention 2 things. From a cost perspective, and one of them comes from experience with the Medicare program. One of them is from the pharmaceutical and medical device industry. So from the Medicare perspective, observing the way the program grew over the time that I was involved with it, there really were several drivers. Chronic disease, clearly. The fee-for-service system of payment, where you pay more the more that gets done, drove a lot of costs. And we saw that particularly in the areas of Medicare where there was most disaggregation of care. So you put that together with chronic disease and a lack of management programs, and that was a really serious problem. I know Ken is well aware of this. The third thing is variation, and a number of people have touched on this, and the lack of the great uncertainty, lack of evidence. So good comparative information that's translatable to the practitioner and understandable by the consumer were things that I think, as we look to improve the system, would really go a long way. So I just leave those observations. From a cost standpoint and the pharmaceutical and medical device industry, I think what we are really looking at now is, in a world where affordability and cost is critically important, not just here in the U.S., but we're looking at India, we're looking at many developing and emerging markets. The issue that we are focusing on is, can we better target patients who are going to benefit? And we have started to do, both in this country and other countries, ways of developing performance arrangements or agreements with payers that would get better at that issue of, instead of having medicines or procedures go to patients who don't benefit as much, that we both support the development of more information through evidence development that happens after something's in use, or arrangements that more or less will share risk with the payers as a way of trying to mitigate some of those costs. So I think there's a responsibility on the part of industry to be involved and be part of the solution. I will just add that despite the fact that these technologies actually represent a fairly small portion of the total healthcare costs, we're aware that the uncertainty does drive utilization around that. And so comparative effectiveness research, we think, has to look at the process of care that goes beyond just a limited procedure to what's going on around that, what prevention, what follow-up. And I would just say that, by the way, the proposal to bring post-acute care in with acute care and looking at that whole continuum, which was in the President's budget framework, really looks like it has great promise, because I think that's going to stimulate innovation that reduces complications, improves outcomes over the course of a treatment.
I'm smiling because, of course, you worked on that, what,
I did.
12 years ago. So we all know, I mean, Tony, I hope you're wrong. I hope we won't be here in 10 years.
I'm betting
Let's
that
put it
we
this
won't.
way, Dave and I won't be here, but anyway, we won't be here. I don't think you will be either.
I'm on your side of the ledger on that one. I think we can get through it now.
I do too.
Really do.
I do too. You don't seem like a patient man. I want to call on Jane Horvath, who's also worked on these issues.
Theodore Roosevelt had it on his agenda in 1909.
Well, and
Resolve the healthcare crisis.
that's quite true.
The centennial anniversary might be the time to do it.
The president kicked off this White House forum earlier in March, noting that in the room, the East Room of the White House, is a big portrait of President Teddy Roosevelt, and he tried unsuccessfully. But this time, we're going to get it done. Jane?
Thank you, Nancy-Ann. And I just, there's so many great ideas in this room, and, I think they all, the problem would be weaving them all together. The complication or your challenge is
You're going to help me with that.
weaving them all together. I'm going to try not to be redundant and focus on some other things that Merck has been thinking about. And I think sort of overall, our framework for thinking about cost, we agree coverage is critical to this, but ultimately I think you need to do both at the same time. And possibly stage things to create room for coverage increases in access. But one thing that hasn't been mentioned here, overall, Merck sort of views this as building on sort of the unique aspects of the American healthcare system, which is, it's a competitive marketplace in a lot of ways. It's an innovative marketplace, and I just don't mean science-based innovation. It's innovative in delivery system and in benefit design.
And that's a good thing.
It's a good thing, and I think we're thinking about how do you up that game? How do you incent the best of the system? And I think we're looking at all things that would sort of change the rules of the road, create competition at all levels in the system along axis of value. And, value for the consumer and value for society overall, which is, price and quality, however you calculate that out. But those are sort of the fundamentals. And then what are the levers? What are the tools to do that by? And one of the big ones that no one has mentioned here today, so I'll be the skunk at the party, which is the tax treatment of healthcare. That's sort of at the 30,000-foot level of using a lever that's available to incent different behaviors and put how you structured sort of general pressure on the system going forward to change the axis of how consumers view healthcare, how health plans provide it, how doctors do it, and how suppliers like Merck enter the system and approach the system. So that's like a 30,000-foot level. And then I think reimbursement systems, and obviously Medicare is the main tool at the hands of the federal government, but aligning incentives, and what Kathy was referencing, sort of these bundled payments where you're aligning incentive across care settings, and everything in that bundle then has to prove its value relative to everything else in that bundle. So that that implicates suppliers and providers and all sorts of things.
Everybody at this table. And
Yes.
It does.
And then, the last thing I'll say, which has been said before, but I think it's a really important piece, is the comparative effectiveness research. And I think, we believe that there really needs to be an independent entity that's very well funded into the future that we can sort of rely on to start sort of expensive analysis going forward, more than an appropriated process that we have now. So I think we feel that the comparative effectiveness work that was started is far from complete. Like, that's not done. So those
Right.
would be our points.
And I would note, too, I was joking about how long it takes for things to happen, but there's been a lot of progress made. When I hear people around this table talking about creating better incentives and bundling payments, it wasn't so long ago that was very scary to everyone in the bundle. And now I think we've had more experience with understanding what you just said, which is that we all have to show we're adding value here. For me, it's not so much a question of are we spending too much money on this. It's too much relative to what? If we're spending it and getting great value for patients, that's a good thing for our country. If we're not, then it's bad for our economy. And unfortunately, we tend to be, I think, closer to the second part of that equation. But it's big for everyone to be talking about in the constructive way that you and Kathy and Steve have talked about comparative effectiveness and getting it right, but openness to looking at how do we make sure that patients are getting the right treatment. So that's actually very big. Glenn, you had something you wanted to say.
Sure. Well, thank you for the opportunity to talk. I think the case for healthcare information technology and the value of it has been effectively made by President Obama, also by David Snow and Dr. Mayer and a variety of people around the table. And at Allscripts, we think that virtually everything that people have talked about today depends on information. And the issue is we don't have reliable information today in healthcare in many respects to make these decisions. We have the best physicians in the world. We have the best nurses in the world. But when Dr. Mayer held up the pen, what we haven't done is equip their hands with the kinds of information that every other industry in this country has to make better decisions. And so we're as electronic health record providers and the leader in electronic prescribing, we're very supportive of wiring healthcare. But that said, we believe that the risk here is that we take paper silos and we make them electronic silos. So what we'd like to see is the discussion moves from not only wiring physicians and hospitals and healthcare organizations and care management and the like, but we've got to connect it all. And therefore, all of those $19 billion have to be tied very tightly to forcing the vendors and all of the different healthcare stakeholders to have a vested interest in interoperability, in the seamless exchange of information. And we think that's going to be the critical component. If you use the example of computers, you remember when all of us had our first personal computers, they told us we'd eliminate paper. And the next 10 years were the best 10 years the paper industry ever had. And the leading...
We're printing everything out? Or?
Exactly. And the leading category was computer paper. But then something changed. The internet came along. We connected those computers together, and people started sharing information. The U.S. Postal Service started delivering less mail. And all of a sudden, we saw an explosion of new services that provided information to all of us, like Google, like tickets online, and the like. And imagine if we had that same kind of explosion for our physicians and nurses and caregivers where information could be exchanged. You know, products like Microsoft Health Vault that allow you to store that information and make it accessible to anyone in the healthcare equation. I think that was mentioned before, that kind of capability. So the products exist today. What we need is the leadership to force the interoperability. We need a lot of physician leadership to say we're willing to make the changes in our behavior, because it's not about technology anymore. It's really about making the changes in business practices and making the changes in behavior to get physicians to use it. But again, we applaud your efforts in the discussion, but now we believe the time is now. It's time for action, and the people around this table with the leadership of the administration can make it happen. So we're excited about the opportunity.
That's great. Paul Marchand?
Thank you for inviting us, and thank you for allowing us to speak. I'd like to throw another big agenda on the table that hasn't been discussed yet. We work with people with significant developmental disabilities. These people are not going to be cured. Their disabilities are going to be lifelong. They clearly have health challenges at some points of their lives, but for most of them, the biggest challenge is long-term care, long-term services and supports, and it's extremely expensive. And this is another place where huge reform is necessary to make the necessary good fiscal decisions and good people decisions. There are 10 states now in our country that have no institutions serving people with severe intellectual disabilities. State government has simply said, this doesn't work, it's too expensive, it doesn't make sense, we're out of the business. However, there are still 40-plus states that have a huge investment in places that cost over $200,000 a person a year for a program that literally sucks. It's terrible for people.
Well, I knew this was a blunt audience. I did warn you we're on C-SPAN.
How do you really feel?
Let's keep it there, all right?
And I am essentially paraphrasing many of the people who have lived there at various points of their lives and have told me that that's what they believe those programs are. There are places to, there are ways to reform that. There's pending legislation, the Community Choice Act, the Class Act that Senator Kennedy has us introduced, that will shift us from institutions, including very inappropriate nursing home care for lots of people with developmental disabilities, back into their homes with good services, back into community-based services that make so much sense. And one last point, on the healthcare provider area, we run into so many physicians, nurses, and other practitioners who have zero training in how to deal with people who have great difficulty in communicating their healthcare needs. When you're dealing with someone with a severe intellectual disability, almost no communication skills, and they're very sick, and they can't tell you why they're sick and how they're sick. And physicians get about a week's worth of training in their entire system of education on disability. It's not working, it's unfair, and that also has to be remedied. Thank you.
Thanks. I'm going to call on Mal. You talked about long-term care, and Mal's representing the home health industry. And then I want to get Scott and Tom Epstein into the equation to talk about the insurer perspective. Mal.
Thank you, Nancy, and I've had the opportunity to work in the home care arena now for 30 years. I've had the opportunity to work in the home care field for 30 years and severe disability. For example, Christopher Reeve was in our very complex wheelchair. We invented the first processor control chair. But what I wanted to say is that the greatest words a patient wants to hear is they're going home. They really want to be home. And sometimes there's not a family caregiver to keep them at home. But as I've watched this industry evolve over 30 years and the technology now that is available in the home, it's incredible. We've been a part of that. And to see and try to guess what's the next protocol that's going to be done in the home. Clearly, we can now create a hospital room in the home. We could create that type of situation in the home. And generally, the caregiver today is a family member. They're not paid. The house is rented or owned. A lot of caregivers today are trying to get some recognition that they've got round-the-clock care, and so I look at home care as sort of a small embryo that's grown up to a very small part of the Medicare budget now. But it's the trifecta of health care, I call it, because it's patient preferred. People really want to be home if they can be home, including people with disabilities. They want to be independent, and a lot of our laws conflict with allowing them to really be home. It's clearly lower cost. Many studies by insurance companies, varies all over the place, but a significant savings. And there's a lot of evidence that the pathogens you find in institutional settings and hospitals aren't present in the home. The infection rate's lower at home. So you got better outcomes, you got lower costs, you got patient preferred health care. And finally, we need to get these emergency rooms unclogged. They're full of primary care visits, and they need to see primary care physicians, frequently have an outpatient procedure, and go home. They don't need to be admitted into the institution. So at the risk of being accused of being a silo today, I do feel the comments that have been made about, we need to come together. The government encourages the whack-a-mole. Read about that in the Wall Street Journal, where we have to pay for something that's good. Somebody else has to pay for it. I don't think that's really the right incentives, and the government needs to decide what is the most cost-effective area, and let's provide the incentives to move it in that direction. Or how are the outcomes the best, and move it in that direction. I think a lot of the incentive systems today don't happen what really should happen. Thank you.
Thank you. Scott?
Well, you mentioned me and said that this would be an opportunity to offer an insurance perspective, but I would just tell you that Group Health is an insurer, but we're also the largest care delivery system in the state of Washington. So
you can talk about either one.
I live constantly with this issue of being schizophrenic, and I'm the great thing is it gives me the choice to be whatever I want at any given point in time. But actually, I think what's interesting about this organization, Group Health Cooperative, is that it is both. And it creates a laboratory for the experimentation with a lot of the innovations that we've been talking about for the last hour and a half.
Ed Wagner's model, isn't that
Ed Wagner's a colleague of mine, and I get a kick out of the fact that people refer to Wagner's chronic care model, and I think, well, that's Ed's work, right? But so I also would just say that I won't reiterate many of the great points that have been made after an hour and a half. Most of them have been made, but I think I would amplify the fact that there are places, and I would say my organization is one of them, where we have the opportunity to experiment with the creation of real alignment that will get at what I believe is, I think we've affirmed this, the underlying issue, and that is our medical expense trends. And we can lower those trends. It's the only way to increase access for people who don't have access today. But how do you take this incredible information technology, the evidence that we have today, the trained professionals in our organization, on and on and on, and engage our patients themselves in a system where everyone is aligned in their incentives around better health for the patient, him or herself, or as a population. And I would say that the real trick to solving this one is finding a mechanism by which we can create that kind of common alignment that brings all the different parts. And we should remember chronic illness drives most of our costs, and most healthcare is provided in the home. And so how are our healthcare systems aligned with patients to make sure that the work that they're doing to promote their own health, years before they're ever even hospitalized, whether it's by email or with their medical home or however it might be organized, our systems right now don't promote that kind of connectedness and alignment. Our view is that while all we've talked about are elements, fundamentally we need to find a mechanism. And here's my point about insurance. I think largely through payment reform, we obviously